Oncology Nursing Podcast, where ONS Voices Talk Cancer, a resource from the Oncology Nursing Society. Through conversations with subject matter experts, we examine the important issues in oncology nursing, from new treatments to patient-centered research to advancements in clinical practice. Join us as we hear from nurses in all facets of oncology care, from bedside to bedside and everywhere in between. Welcome to the Oncology Nursing Podcast.
Welcome to the Oncology Nursing Society's Health Policy Conversation with United States Representative Donna Shalala. My name is Alex Stone, and I am ONS's Public Affairs Director. These are challenging times, and nurses are on the forefront of the global pandemic. Advocacy, normally a very personal, interactive exchange, has had to evolve. Social distancing and sheltering in place requires us to find new ways to get the important message of the role of the nurse in healthcare to decision makers. And with that, we'll turn this over. ONS's CEO, Brenda Nevidjon, will conduct the interview.
Thank you, Alex. We are honored to have Representative Shalala with us. She has been a champion of nurses throughout her whole career, so this promises to be a wonderful conversation. I do want to mention a few things about her. You may know that she was the longest-serving Secretary of Health and Human Services during the Clinton administration. She's been president of universities and has worked in the nonprofit world. You may know or may not that she was awarded the Presidential Medal of Freedom by President George W. Bush. She is an honorary fellow in the American Academy of Nursing, another prestigious award. And of great importance to all of us is that she chaired what was then called the Institute of Medicine, the committee that produced the report, The Future of Nursing, Leading Change, Advocating Health. That came out a decade ago, and I believe it is still the most downloaded and purchased publication of the national academies. So as we get into this chat, I know there's going to be many things we're going to want to talk about, but I wonder, to start with, if you could tell us how it came to be that you, a non-nurse, a non-healthcare professional, came to be such a visionary and advocate for the nursing profession. You've had connections to schools of nursing and health systems. Was there a moment when you realized that you were called to serve, to be that strong voice and work with nursing to advance the profession?
No. I obviously have run or led 3 universities that had very good nursing schools, starting with Hunter, then the University of Wisconsin, and finally the University of Miami. I had very talented nursing deans who educated me on the profession, both at the undergraduate as well as the graduate programs. And I saw nursing evolve into the doctoral program, the DNP, and other advanced practice degrees. That's number one. Number 2, I ran large healthcare systems, and it was very clear to me in academic healthcare that we needed teams, that's the way you got quality healthcare. It wasn't nurses reporting to doctors, it was equals working together to help patients, and that's the way you got quality healthcare. And finally, it was my interaction with the VA, where they have fully integrated nurses much more than any other part of the healthcare system. And in fact, I just wrote the introduction for a book on the history of nursing in the VA, because I've been fascinated by how a single payer system, basically, when people say to me, well, you want to turn healthcare into a socialist system, we actually, the VA system is as close to that as you can get, but they fully integrated nurses. So over the years, I learned a lot about nursing. And when I got to HHS, I appointed a lot of nurses, not to jobs that had nursing in their title, but major health policy. Because from my point of view and my experience with the NIH and with the Institute for Nursing Research, the field, the scholarly field, focused on the patient in particular. Since I had read some of the literature, I was pretty familiar with the role of nursing. When the Institute of Medicine, now the National Academy of Medicine, called me, I said no. I was down in Miami, and I know how much work it is. I had chaired a couple of panels for the National Academy of Sciences and sat on panels for the Institute, and it's a lot of work to chair a panel. Frankly, the National Academies kind of put their thumb on you, and they drive the report, and that's just not my style. I said, okay, but I get to pick the panel. Well, they were shocked. I said, you can give me names. I said, but I know about nursing reports. If this one is going to have an impact, we have to have the right timing and the right panel. I actually said to them, I don't want 5 deans of nursing on the panel. I love nursing deans. I'll take one. But I want people that know healthcare, including the former head of CMS, Bruce Fladdick. I mean, I got Bob Reischauer, who ran the CBO, but I wanted a mixture of men and women who cared about healthcare. And I wanted some younger people. So we had 2 young nurses, one a nurse midwife and one an academic nurse, a PhD, because I wanted a mixture of ages, but I didn't want it to end up as the usual suspects because I was concerned that we needed a broader representation constituency to really have an impact and say very strong things. And it worked. I mean, there were plenty of nurses on the panel and people with nursing backgrounds and plenty of consultants that came in and plenty of hearings that we had around the country. But I just had a clear vision of what could move the profession. I obviously knew about scope of practice and some of those issues, but I had a pretty clear vision about how it could have an impact. It ended up having an impact.
Right. I think, looking back the 10 years when that report first came out and the impact that we as nurses felt to see that and read that and be able to see that the input was there from a diverse committee and a diverse process. And now looking at today, I think there are very measurable changes that have occurred. Hope you see them as well, that report was a foundation that brought change.
Well, it raised the standards in the sense that almost every hospital in this country now require a 4-year degree.
Yep.
It moves scope of practice, which, by the way, the Academy of Medicine wanted me to take out because they said it was too political. And I said, that's the core of the report. We want nursing to be able to practice up to their training. And that's what the report's about. And so I refused to sign the report until they backed down. That piece combined with requiring 4-year degrees, and we weren't discriminating against people with 1-year or 2-year degrees. We talked about pathways. And then we were careful to talk about partnerships with the medical profession, that this had to be a team. And I actually went through the report myself and made sure that our language was sensitive on that particular subject. The last thing we needed was for the medical societies to just say this is dead on arrival, as opposed to seeing it as what it really was, and that is a report to improve the quality of healthcare for everyone.
Right. I think one of the things that I've seen with schools of nursing that did step up and come forward with second degree programs so that people already with a baccalaureate degree in another field who wanted to change fields didn't go through that traditional process that would have been lengthier than the accelerated programs. You mentioned the DMP, and we know that has really had an impact in having that doctorate in nursing practice along with our PhD, but we are seeing the PhD enrollments declining some and graduates declining some, which does have us, the Oncology Nursing Society, concerned because this organization from its earliest inception 45 years ago was built on science and evidence base and had such a strong group of nurse scientists in our organization.
And we need faculty. And we did get some foundations to finance PhDs as a result of the report. But it was very difficult to get people who had been in practice to enter a PhD program, not because they weren't interested in research, but to give up a salary to do a PhD was a real challenge. So we did get some foundations to start to pay, arguing that we wouldn't have faculty in the nursing schools if we didn't. My great failure in that report was that I wanted nursing schools to hire people from other disciplines. One of the things that strengthened graduate programs in education was when they hired economists and sociologists and political scientists, policy people. The accreditation made it tricky to do that kind of thing. And I'm still disappointed about that. I chaired almost all in the 1970s when I was at Teachers College at Columbia. I chaired almost all of the PhDs in nursing. If graduate students decided to do a PhD, you had to have a member of the PhD faculty.
Yeah.
So I actually chaired those programs, and it had an impact on me, but we did produce future deans and faculty members through that.
Yeah.
I don't want to downplay, though, the one-year LPNs or the two-year programs. And I was much more sensitive to that than many of my colleagues. I came out of Ohio, and I have family members that work in nursing homes that have those one-year degrees. I want to make sure that people have the opportunity to get to four-year degrees and that there's a pathway for that, because obviously we're trying to strengthen the profession in the process.
I think that's very important. And those of us who grew up in a time in nursing when our teams were with medical nursing assistants and LPNs understand the importance of those, although our environments are so much more complex today. If I could, let me shift a little bit away from nursing and all, but so this is your first time in the House of Representatives representing Florida, well, the Miami area. I don't know, it's not the whole state, but probably the whole state likes to claim you. You've come in as a freshman 2 years ago, probably with more experience, more knowledge than any freshman member of Congress has ever come in with. So what's it like to move now into the legislative aspect of policy making?
It may be the easiest job I've ever had because it's all policy. I mean, it's the intersection between policy and politics. But I have no real responsibilities. I describe myself as a freshman, but not a rookie. And so I've been able to work on a whole set of policy issues. I sit on education and labor, which has responsibility for ERISA, the private healthcare plans. I'm not on the big healthcare committees, but they've been very respectful of my knowledge. I've just released a bill with Anna Eshoo, who chairs the Health Committee in Energy and Commerce, which is the big health committee. And Anna and I knew each other before. So people have reached out to me to support their bills because they think I add credibility to them. Mm-hmm. But the chairs in particular have been very respectful and have reached out not only to get my support, but to get my ideas. I co-sponsored with Frank Pallone, the chair of Energy and Commerce, the big bill on vaping to stop teenagers from vaping. So I've had lots of opportunities. It's a lot of fun. I mean, most of my colleagues are just dead tired. It's a lot of fun for someone like me who loves policy and likes talking to people and likes this interface between policy, particularly health policy, and politics. I don't particularly like the fundraising because we have to run every 2 years.
Right.
I've done work with my community, and I knew the community pretty well before I ran. I know it even better now. This pandemic has turned us all into really local government officials because people are really hurting.
What are you hearing mostly from your constituents? Is it in terms of the economic impact or the health impact of this?
It's economic impact. We heard initially, I can't get a test. Should I get a test? I mean, just getting, the public health messages were pretty straightforward. It was wash your hands. It was pretty low tech. Wear a mask, wash your hands. That's kind of fundamental low tech public health. It does make a difference. There's no question about it. But the consistency and the clarity of the message, we've just tried to reinforce over and over again. But I'll tell you, people, it's the economic things. They couldn't get on unemployment, the PPP, the small business thing was messed up because the banks went first with their big clients as opposed to the people that banked with them who owned small restaurants. I represent Miami Beach and the port and a lot of hospitals. And the hospitals, of course, put off, someone called them non-essential. They were essential, put off a lot of work in the anticipation of their beds filling up. The beds didn't completely fill up down here, particularly in cancer. You can put some of this off a little bit, but you can't put it off. People are going to get sicker. And so that's been a challenge. But, the people that are calling me are crying. I mean, we're nurses and social workers at the end of the phone. They're really scared. And that's what we're hearing more than anything else.
Well, we hear that from our members. We certainly have heard from our members across the country the impact when non-essential services, non-essential surgeries were all canceled. I saw a recent report that some of the cancer screenings are down 80 to 90%. That'll have an impact longer term. Our president, Nancy Houlihan, is at Memorial Sloan Kettering, so she's been in the epicenter, if you will, of this. And she has a question she would like to ask you. So I'm going to toss this over to Nancy.
Thanks, Brenda. Congresswoman, your understanding and support of the nursing community is a needed and refreshing respite to a system that too often favors healthcare providers. ONS greatly appreciates your leadership in participation in the Institute of Medicine report and helping to pave the way for continued strategies for the nursing profession. So we're curious, what did you learn from that experience about how nurses are perceived by other providers, by patients, and by decision makers such as yourself? And as a follow-up to that, what should nurses be doing or doing more of to educate and advocate for our profession that would help us to better inform your congressional colleagues on the role of the nurse in healthcare?
The hearings were really had an impact on me, not simply because leaders in the nursing profession testified, but what I learned and what I've learned over the years is that the patients' families have enormous respect for nursing, and that's reflected in the polls. Their interaction is often with a nurse in the healthcare system, not with other providers. Their first interaction in terms of someone taking care of them is with a nurse, and they remember that. The other thing I learned is that nurses underestimate their power and have not used it as effectively as maybe some members of the medical profession have. It's a lack of confidence and understanding, I think, of the real political power of nurses. There are more of you than of them. And having a clear, consistent message with individual members of Congress, it is what you do is relate to the patient and you're patient-centered. That's more consistent with a congressional experience because it's the stories, it's the interaction with people that shapes our ability to make good policy. And most leaders in nursing don't have a relationship in their community with their congressperson. That's not true of the docs. And so I just think nursing and the nursing profession and the professional organizations need more self-confidence that they really rank number one in the polls, and you need to act like that because you have tremendous public support. I sit on the same committee with Lauren Underwood, who's a nurse. Whenever we introduce anything that has to do with nursing, everybody votes for it.
Well, that certainly is apparent currently with the, kind of recognition of nurses and their involvement in the COVID-19 pandemic. Recent conversations is how do we hold on to that as a profession and leverage it going forward, because this is our significance.
And you have a bigger constituency now than you've ever had. Even though it wasn't really the design that nursing wanted in the minute clinics and putting nurse practitioners in particular in our drugstores or in Walmart, some of those models, or in urgent care centers, depending on what state you were in, that gave you a part of the business community that would lobby for you, as well as insurance companies are starting to recognize the importance of nursing and that they also can be part of the coalition. So I just think nursing has an opportunity here. With the report, we started into a golden age for nursing, and I believe that it will continue.
I agree. And I think certainly our advanced practice providers are in a position now with reimbursement for telemedicine is already having a huge impact and will going forward.
So the question, though, to that becomes how do we sustain that with some of the waivers that have occurred because of the pandemic and things that have been allowed? How does that get to be sustained, and what can we do in our advocacy? And I will say, I've been a member of the Oncology Nursing Society for almost its 45-year history, not the whole 45 years, but where we are today with our members and the advocacy is so different than when I first started in this organization. But I think there is work we do need to be doing to sustain some of the models that we have seen emerge and be allowed under different waivers of regulation.
Yeah, we're going to need good data because what the data, I believe, is going to demonstrate is that it made a difference in quality. It was not only scope, it was quality. A temporary temporary waiver, it's easier once you've done it and have demonstrated that it really can have an impact and that it's fair. It's easier to sustain it. And we will try to turn all of this into legislation at some point.
Yeah.
Good to hear.
Ann Ireland, who is one of our directors at large and is at the City of Hope out in California, in greater LA area, also would like to ask you a question.
So when 2020 was announced as the International Year of the Nurse and Midwife, we were all excited to plan for and celebrate Florence Nightingale's 200th birthday. Little did we realize that nurses would be at the forefront of a global pandemic. Nurses from around the world have advocated for PPE, access to care, and scope of practice, which you alluded to earlier, and in many cases help to break down barriers on these topics. It has certainly been very moving to hear and see the appreciation and the accolades from the public. As nurses, we often say that these actions are simply us doing our jobs by honoring our commitment to society. I'm interested in hearing from you from a global perspective. How do you feel the perception of the nursing profession has evolved during this crisis? And where do you feel the United States is in comparison to other countries?
You know, as you well know, the nursing profession, it's uneven around the world in terms of training, but this crisis has brought out the importance of well-trained nurses in dealing with COVID-19. And I think it actually has elevated the profession in a way that even my report didn't do, because people are talking about nurses and they're talking about nursing, and they're actually talking about nursing all over the world, not just in Europe, for example, but in other parts. I think this is an important point in history for nursing, and taking advantage of it, and I can't repeat this enough, means that you can't be so humble.
We have one more on our panel who would like to ask you a question, and that's Lizette Gomez Rios. She is from your neck of the woods and is chair of the Miami ONS chapter's education committee and also has a day job. She's been very active in health policy, both locally there in Miami, but also has participated in our national Hill Days. So Lizette, I'm going to toss this over to you.
Hi, Lizette.
Hi, thank you. Thank you, Congresswoman Shalala, for joining ONS today. As a constituent of yours, I am so pleased and proud to have you and a strong voice in the U.S. Congress promoting the role of the nurse in healthcare. Here in Miami, we are confronted COVID cases at a higher rate than the rest of the state. What public health protocols should the state be engaged in to continue flattening the curve, and how can nurses be part of those, especially now that Florida reopened?
You know, I have not minced words that I think it's too early to open most of the country. Flattening the curve isn't good enough. You got to be going down, and you've got to go down for 14 days. If you read these CDC reports, if you listen to Tony Fauci, even to Deborah Burke, you need actually to be going down, because flattening the curve doesn't allow you to do contact tracing. And we haven't starved this virus enough in the United States to avoid the kinds of spikes that are going to occur. And I'm afraid that nursing is going to be on the front lines for a longer period of time than they really should be, because our political leaders haven't had the guts, first, to hit the thing with a hammer when we first heard about it. The public has been far more responsive. They stayed inside and saved lives. But there's a certain kind of fatigue that sets in, and we have to be very creative about, I was out walking around at 7 o'clock in the morning. There were a number of people walking around. Everybody had masks on, at least in my neighborhood. I'm just very worried that we still don't have enough testing. We still don't have enough PPE. This virus is flattening in some places, but not really going down for a long enough period of time. In South Florida, we're still seeing too many deaths, particularly in nursing homes where we need to focus, as well as in prisons and detention centers. These are petri dishes. I very much want to open the other parts of the hospitals, particularly oncology, where I don't think we should wait much longer, but that requires that the hospitals actually separate sections for infectious diseases and are extremely careful, which they know how to do. Hospitals has been doing this for years. But I worry very much that we're opening up, even gradually, before we have testing for everybody. We haven't tested everybody that works in a drugstore, everybody that works in a grocery store, and we certainly aren't planning to test everybody that works in a restaurant, which is what we probably need to do. I was on a Zoom call earlier today. We were talking about McDonald's is not only going to test all their people, Amazon's going to test all their people. McDonald's going to clean their bathrooms every half hour. I mean, that's the kind of thing you have to do if you're going to open up. And you can't just test people that have symptoms. If they're doing things like delivering the mail or serving in a restaurant, you've just got to have the proper testing and the proper equipment. So I've been a skeptic about all these states opening, though I understand the fatigue that has set in. But I do think there are creative things we can do to get people out. And we're doing some creative things with restaurants. A lot of the restaurants in Miami are going to serve outdoors, which is much safer.
Yeah. I think another piece of evidence will be as states open up, is there really an influx in terms of the economy and revenue? I heard somebody on the news this morning, a small restaurant owner saying, he was opened up over the weekend and he only had about 10% of his usual business. And what he said was, if that's all I'm going to have, I can't sustain being open.
And just think about childcare centers. If you say to them, you have to do social distancing, so they have 25% of their clients, they can't survive on that.
No.
So we have to think a lot of these things through. By the way, the Scandinavians do their childcare outside. It's safer in terms of infectious disease. They have much lower rates of infectious diseases as they do more outside with the little kids. I'm not sure we're up to that, but we've got to teach little kids in the developing world to prevent infections. When the kids go to school, the wash basins are out in front and the kids wash their hands before they go in. Amazon is putting 3,000 wash basins all over the country so that their employees wash their hands when they come in. I mean, they're practicing good public health practices, but I'm concerned that we haven't driven it down enough so we can do the kind of contact tracing that we need to do, and then isolation for people that are in fact infected. And we don't have a treatment yet. I've been one of these people that hasn't held out hope for a vaccine. I think a safe vaccine takes time. Even though they're fast tracking it, Tony Fauci will not allow a vaccine to go out unless he thinks it's absolutely safe. But a treatment is something else. If we can save lives, if we can catch these infections early, and if we have a protocol, remember, we never got a vaccine for AIDS, but we got a treatment. It's easier to make a pill than it is to make a vaccine. So that's what we're looking for.
Many nurses are unionized. Does being unionized potentially be a hindrance for nurses in terms of relationship building? Is it make nurses appear less professional, particularly when working with elected officials?
No, I don't think so. I mean, I work with nursing with SEIU and AFSCME, and AFT now has a large number of nurses that they represent. And then there's the whole California group. Often they have a clear list of things they want you to do, and they do get access. Now, they also get access because they contribute to campaigns. Members of Congress, they interact at their fundraisers and other opportunities. And I don't think this is an appropriate place for me to advocate for unions, but I've worked with those unions for years. But there are some places that don't have unions. And that doesn't mean that an organization like the Oncology Nursing Society can't see their local legislators. Now, it's not just the members of Congress. It's the state legislators when you want to push them on scope of practice. You ought to know every state legislature and everyone who had a mother or an aunt or a cousin that was a nurse.
Yeah, that's an excellent point. That's one of the reasons we've put more effort at the state level. ALEC has been very much on the forefront of moving some of our advocacy out to that state level because of that. So,
well, scope of practice is a state issue.
It is.
Some things with Medicare, we can do some temporary things on reimbursement, but it's a state issue. Licensure is a state issue.
Yeah. So the last question looks to the future. What measures might Congress be able to move forward to help with the possible decrease in young people wanting to become a nurse? It's interesting. I was in a call earlier today in which this issue was being discussed with what's happening with the pandemic that is showcasing nurses very positively. It's also showing the scariness of being in the midst of a pandemic. So do people want to come into nursing in the future? What can be done at a congressional level to support the pipeline of nurses?
You know, we had this during AIDS. AIDS scared off some people. So we've gone through this before. If you're afraid of infectious diseases, don't go into nursing because this is like the 5th or 6th one we've gone through in our lifetime. We're going to go through some more. I mean, this is what nurses do at the end of the day. And we've just got to attract people who have a sense of adventure and a service. And frankly, to make sure that we pay people appropriately. If we want them to practice up to their training, we've got to pay them. And frankly, the finances of nursing has changed. I mean, hospitals have upped salaries and changed the roles and done other things. And there are lots of roles for nursing in health insurance and other things. So nursing is all over the place. The hospitals that I've been responsible for often had nurses as their COOs or CEOs. They've taken leadership positions, I think in large part because they're so patient-centered. It's not just a question of worrying about the personnel and the human resource issues, but because they've brought a focus on the patient, understanding that the patient is really the customer, as they would say in the business community, that great institutions are patient-centered.
Right.
Academic health centers struggle to do that. So I see a future for nursing. I think we can attract lots of young people into nursing and older people into nursing. I think that the accelerated degree has made a difference. And I actually think that DNP has made a difference in terms of keeping people in. I don't know how many contract nurses we're using anymore. We pretty much, after 2008, brought people back to nursing. I haven't looked at those numbers in a while, but if I was going to start out in the health professions, I'd start out in nursing. There's no question.
Yeah.
Then run for Congress.
Well, we are pleased that there are one or two in Congress and would like to see more. And you never know. We may be able to at some point have more nurses in Congress.
Let me also say that oncology is the hot place in nursing.
It is.
There's no question. We've made a huge investment in this country in cancer and will continue to do that. So I have great admiration for all of you because of the profession you've chosen and because of the leadership you've shown in this terrible pandemic. So thanks for the invitation.
Well, thank you. And we appreciate your passion and your leadership at the national level.
Thank you for listening to the Oncology Nursing Podcast. Tell us about your favorite part of this episode by leaving a review on iTunes or wherever you download your podcasts. For more resources and information about oncology nursing, visit us at ons.org or voice.ons.org.